you all tonight. Dr. Galland and Ortho NC have begun treating patients with the MISHA Knee System, which represents a breakthrough treatment for knee osteoarthritis. I'm sure if you're on this call, many of you are likely struggling with knee pain and osteoarthritis, and that often also comes with functional limitations. You're unable to do the things that you want to do, and oftentimes you start with the non-operative care injections, and sometimes that's ineffective for many people, but they're not ready for a knee replacement. And that's really where the MISHA Knee System comes in and is a nice option for new patients. So Dr. Galland and his team have begun treating patients with MISHA. And in this presentation, it'll probably take about 15 to 20 minutes. We'll go through what is the MISHA Knee System, how does it work, who is it for, and what are the next steps to really get started. Once we're done with the presentation, we'll open it up to Q&A. So please submit your questions in the chat. And without further ado, let me introduce the star of the show, Dr. Galland. So Dr. Mark Galland did his medical school and residency at Tulane. Afterwards, he served our country, being in the military orthopedic surgeon down at Camp Lejeune, so not too far from here. And then afterwards, after about 5 years, joined really private practice in the Raleigh area in Ortho NC. So he's been treating patients within this community for about 20 years or so. Multiple orthopedic issues from knees to shoulders to elbows and so on and so forth, non-operative care to surgical care. So as a board certified orthopedic sports medicine surgeon, Dr. Galland is primed to help a lot of patients with knee osteoarthritis that are right in that at treatment gap. So without further ado, let me pass it over to the star of the show, Dr. Galland.
Good evening, everyone. Thank you for being here. I hope that our presentation tonight is very helpful and instructive and answers all of the questions that you may have about your condition and about the ways that we can help solve the problems. As Drew mentioned, I'm an orthopedic surgeon and sports medicine specialist. I have a history in the past of doing knee replacements and partial knee replacements. I no longer perform those procedures. I really am focused on joint preservation and finding ways to help the patient who has these problems without using a knee replacement as an option. And as a result, the MISHA, it truly is a breakthrough option for patients with knee pain and even early to moderate to moderately severe osteoarthritis. It really fills a void between non-surgical and the most extreme surgical treatment option. I'd like you to just take a second to review this video to learn a little bit more about the MISHA from the patient perspective.
I was desperate, so I tried non-surgical interventions, every injectable known to man. I was seriously considering knee replacement surgeries in my early 30s.
You're going to tell me I'm going to be in pain like this for the rest of my life? I'm 19 and I can't walk up a flight of stairs.
The pain was pretty tremendous. I got some cortisone injections. I tried some physical therapy. No matter what I did, it wasn't helping.
And you said, well, you've developed osteoarthritis now in your medial knee joint. And he said, well, there's this new thing that you might be perfect for.
Cutting-edge technology is giving people with knee pain hope. UC Davis Health is one of the first in the country to offer it.
OHSU is the first in the nation to use a leading-edge repair technique to treat osteoarthritis in the knee.
This implantable shock absorber has fundamentally extrapolated the brace concept to an implantable device that then takes the load of gravity and dissipates it.
It looked like a miniature shock absorber that would go on a tiny model car.
There was a device that would just relieve the pressure on that part of the knee. It made so much sense. And it definitely was much less invasive than any of the other options.
When you're walking, doing activities, it's going to take about 30% of that shock or that stress on that knee every time you actually put weight on your leg.
It's not just a treatment for arthritis, it's a treatment for health.
Is this a game changer or what?
It's absolutely a game changer. This was what I was looking for and I didn't know it. It is probably the single best decision I've ever made in my life. I don't have pain like I did. I can walk.
I really feel like the device has been just life-changing.
The device is, I think, stemmed off a knee replacement. So I definitely don't need one of those for hopefully quite a while.
Getting the MISHA Knee System implant has restored my hope for the future in terms of my health, physical health and mental health. Being able to run on a regular basis is a big part of my life. It's part of who I am. And having the MISHA Knee System is giving me that back.
We'll be able to treat more patients. I believe we'll be able to tackle this disease in an earlier state and preserve health, keep people working, keep people running around with their kids. I can't wait to have it in my hands more frequently, give to patients.
When I got the surgery, my expectation was if you can walk to work in the morning and sleep without pain and hopefully kick that soccer ball with your son, that'll be enough. I've gotten so much more than that. It really did alter the course of my life.
So the MISHA is ideally designed to help patients with medial or inner side knee pain who have osteoarthritis to some degree. There are 15 million patients in the United States with osteoarthritis of the knee. And the slide says 50% unwilling to have arthroplasty. It's probably nearly all of them. The other 50% probably feel they have no choice. Choice of last resort, a knee replacement's irreversible. It's extremely invasive, and patients are afraid of it with good reason. But before we go any further, let's just talk about what osteoarthritis is. Osteoarthritis is a condition or disease state in which the cartilage or the nearly frictionless weight-bearing surface at the end of the joint is disappearing or diminishing. And we often will focus on how much cartilage is left or how much cartilage is worn, or are we bone on bone? But it's a little more complicated than that. The joint fluid changes and becomes thinner and more watery. The meniscus itself, which is the shock absorber or gasket between the bones, can become flattened, misshapen, deformed, and completely non-functional, and can often result in a rapid or dramatic onset of symptoms. In some cases, almost immediately over a couple of weeks. That is often how we meet patients with meniscal failure and then a concomitant diagnosis of osteoarthritis. The non-surgical options are well known to many people. There's steroid injections, weight loss, physical therapy, and unloader braces, which take the weight off of the worn part of the knee. And all of these are effective to some degree, but they all have a limited shelf life and have limitations on the amount of pain relief that they can provide. The MISHA acts much like a shock absorber in the car. On the left side of the screen, you can see the MISHA diagram animation demonstrating how it works within the knee. And on the right side, you actually see the device itself being tested in the lab. This device has been tested to 20 million repetitions of what you're seeing on the screen, and before it would even show any signs of wearing out. That equates to about 10 years in an active soccer player. And it should be noted that even a knee replacement or a partial knee replacement are only tested to 10 million cycles. The MISHA implant is less invasive than a knee replacement. During the procedure, the surgeon doesn't even enter the knee. An incision is made on the outside of the knee, and the MISHA is implanted against the bone and beneath the skin with 3 screws on each side. The MISHA, as you can see in the diagram, is not much bigger than the key to your automobile. It is performed as an outpatient procedure. One of the most amazing things about the MISHA is the rapid and significant relief of pain. 96% of patients had clinically meaningful pain relief at 2 years post-op. If you look to the left of the screen, the diagram shows a pain score of 60, and at 2 years post-op, down to 14 or 75% reduction. Even at 6 weeks after surgery, the pain relief appreciated was about half already. And even at that stage, there's still some post-surgical pain. So 30 or 50% is very significant. The average time on crutches is only about 13 days. One of the best parts, and one of the ways the MISHA really separates itself from joint replacement, is post-operatively, there are no activity or age restrictions. Once you have recovered from the MISHA implant surgery, you can run, you can sprint, you can jump, you can ski moguls, you can lift weights. So unlike a knee replacement, which has very specific restrictions, you just get back to living your life the way you want to live it. The second thing that I love the most about the MISHA is there are no bridges are burned. All future surgical treatments are available after the MISHA procedure. If the MISHA doesn't work, or if the MISHA wears out at some point in the future, you still have all the options available to you that you had the day before you had the MISHA implanted. One of the most surprising things, and the things that surprise patients the most, is the appearance really is highly acceptable and it's hardly noticeable. You can see on all three of these images, it's hard to discern, except for the scar, which knee has the MISHA. You may be asking, my candidate. Well, if the pain is on the inner half of your knee, if you are experiencing significant limitations in your day-to-day life or your desired activities, if you're living for your knee and not living your life based upon what you want to do, and or if you've had inadequate relief from any of the non-surgical options mentioned earlier, or any of the ones that we haven't mentioned that you've tried. And if you're simply not ready for a knee replacement, the MISHA may be for you. There are no age restrictions, and Medicare patients are eligible. The post-operative recovery and physical therapy is not nearly as extensive as some of the other surgeries that we offer. It is much different, much more streamlined, and to a degree much easier than a knee replacement. You begin immediately after surgery by flexing your knee multiple times a day. And even after you have it, within 20 to 30 minutes after having the MISHA, full extension and full flexion is demonstrable. And after having it, you will be doing this immediately. Early weight bearing is allowed. You use the crutches or the walker until you don't need them anymore. The average is 13 days. We start physical therapy between 3 and 5 days post-op. One of the most important things to understand is I've noticed many patients so far have been so eager and anxious to get better, and their knee has felt so good initially, they're a little too aggressive. And you have to remember that the soft tissue around the implant needs some time to adapt. So there will be some irritation, some irritability, and some swelling in that area. So you want to be careful about getting too aggressive and feeling too good too soon. But there are no activity restrictions. The timeline to return to your full activity is individually based. This is an example. This patient had the MISHA implanted about 40 minutes before this video was taken. The patient is flexing and extending the knee on their own without any assistance. So that is almost a complete and full range of motion. Immediately after implantation, I think it's important to note that even after a simple knee arthroscopy, you would not see this in a patient after a knee scope. Now, one thing to note is a couple of days after surgery, there will be a little bit less motion due to the soft tissue swelling and the pain, but the diminishment is not going to be dramatically different than that. Authorization for insurance, MoxieMed or MISHA, MyMISHA is a prior authorization assistance program, and it works on your behalf to navigate the insurance process. In my experience, both the patient and to some degree the surgeon is delightfully uninvolved in the process, and pretty much all the work is done on your behalf. Medicare patients are eligible, usually immediately. In my practice, just to bring you up to speed on how we learn how to do these things, the onboarding process and the training is an intensive 2-day course that builds upon skills that any sports medicine surgeon already has. And the training is specific to the implantation of the implant. We learn about the experience of other surgeons, patient stories, examples of recovery and rehabilitation, insurance authorization, how to guide our patients through this. And I've been lucky enough to be asked to join the faculty, and I'm now teaching other surgeons how to perform the MISHA procedure. So that concludes the didactic portion of our visit. I would more than welcome any and all questions that you may have.
All right, so sorry for the technical difficulty. So one more instance that you've seen, how have they tolerated the device in terms of how it looks and how it feels?
The device is well tolerated. The appearance is highly acceptable. I would say in patients that are extremely slender, very lean, there may be some prominence. In general, though, it is not something that is visible when viewed straight on or even directly from the side. It is not something that you will feel unless you really palpate or dig into that side of the knee. You definitely can feel it if you dig your fingers hard enough into the knee. In terms of recovery, what I have found, when patients follow the program, they're very pleased. But what I've seen in a couple of instances, I've had a couple of patients who are very high achievers, very eager to resume their active lifestyle and engage in all the activities they had been missing for months and even years beforehand. And they are perhaps too aggressive far too early in the process. And that just creates more swelling and a little more pain than they otherwise would have to bear. I think it's important to note that once arthritis reaches a certain level or meniscal failure reaches a certain level, there may be some degree of pain no matter what option you choose. But a 75% pain reduction is pretty substantial, and it is really reopens your lifestyle to any number of activities that were not available when the pain was much greater than that. But it's certainly possible to be too aggressive too soon.
All right, we get a couple more questions coming in from the audience. So the first one is knee valgus a disqualification for the MISHA procedure?
Knee valgus in and of itself is not a disqualification. Most people do have a valgus alignment of the knee. Severe valgus, more than the anatomic 3 to 5 degrees, may indicate a distribution of osteoarthritis that would preclude the MISHA simply because the arthritis and the symptoms are in the wrong area of the knee. So with extreme valgus, the knee pain may be more anterior or lateral, and that patient would not be a MISHA candidate. However, normal valgus alignment with medial or inner knee pain, you may still be a candidate.
So it's a great lead into the next question. Does this only work for pain on the inside or medial portion of the knee? And if so, why?
Yes, the MISHA is only indicated for medial knee pain. However, I would point out that many patients have osteoarthritis and even some symptoms in their kneecap. As long as the symptoms are predominantly medial and the osteoarthritis is medial, even though there is kneecap osteoarthritis as concomitant or as well, you are still a candidate for the MISHA. The reason it is only for the inner side of the knee is the MISHA is designed specifically based upon the anatomy of the inner knee and cannot be placed anywhere else with any expectation of success. It is specifically designed for that area, and it keys off of specific anatomical structures and is designed to engage the shock absorber and distribute the load at certain positions of knee extension. And that is not possible with the design of this implant anywhere else but the inside of the knee.
The next question is 10 years the expected time frame of the treatment? And is knee replacement the next step after that?
The MISHA has been tested up to 20 million cycles, which would be the equivalent of an active professional athlete. So all things considered, 10 years would be very reasonable. More than 10 years is not out of the question. Individual factors apply, but 10 years is certainly not the upper limit, but it is a reasonable expectation. If and when the MISHA no longer provides the desired duration and expectation of relief, the next step would really be determined by factors yet to be determined. The appearance of the X-ray and MRI, the condition of the implant. The next step might be a partial knee replacement. Could be a full knee replacement. Could be something else that is not yet available.
Can you explain the physics of how the implant works to relieve pain?
Yes. Yes. One of the reasons I believe the MISHA is an ideal implant for the sports medicine surgeon is because in sports medicine, when we are always chasing and reconstructing ligaments so that they are placed in an isometric position. That means they don't lengthen or shorten dependent upon the flexion or extension of the joint. The MISHA is the opposite. It is anisometric. We want the implant to shorten at knee extension or when the knee is fully straight or near fully straight. And that engages the shock absorber to offload the joint. It offloads the joint 30 pounds. And so you might be thinking, well, 30 pounds. As you might imagine, 30 pounds might mean more to someone who's 180 or 200 pounds than it would to someone who's 300 or 320 pounds, but it's 30 pounds regardless. The load absorber, the shock absorber, disengages at positions of flexion so that it does not limit your ability to bend the knee. So that is the rationale, and that is how we implant it.
Will the lifespan of the device be shorter in an endurance athlete, specifically with swimming, biking, and walking?
Great question. The lifespan of the implant is going to be between 10 and 20 million cycles. And so the more quickly you use up the 20 million cycles, theoretically, the implant may not have the longevity. of someone who would spend 40 years reaching 20 million cycles. If you reach it in 10 years, that would still be quite a feat to behold, to reach that 20 million cycles in 10 years.
We got two more questions in the chat. If you fell or had some type of accident that hit the device, could it be damaged?
In theory, anything is possible. There has not been a known or reported incidence of loosening or catastrophic failure of the implant, but certainly I could conceive of trauma that could cause a fracture, unrelated to, but around the implant of the femur or the tibia. The implant is certainly, it's extremely durable and extremely tough, but nothing is indestructible. But in the routine bumps, bruises, and scrapes of life, it's rather unlikely that the implant would be damaged.
All right. And is this better done while there is still cartilage intact before severe osteoarthritis exists?
That's a great question. The 2-year and the emerging 5-year study has looked at all grades of osteoarthritis, from the levels of osteoarthritis that is barely discernible on an x-ray all the way to bone on bone. And every patient, regardless of the severity of the osteoarthritis, has experienced meaningful functional improvement and pain relief. However, the patients with less severe arthritis tend to have greater longevity and are far less likely to progress to knee replacement in the intermediate and short term.
So we welcome any additional questions that come through the chat. You know, one final one from me, Dr. Galland, is for the patients that are on this call and thinking, I'd like to learn more, what would you say is the next step for those patients?
Well, the next step would be to schedule an appointment, either by contacting OrthoNC or scanning the QR code on the left-hand side of your screen, or to visit me at drmarkgalland.com. Any of those options will get you to the right place and get you the answers that you need.
All right. Well, I don't see any other questions come in the chat. Dr. Galland, any kind of final closing thoughts for the group?
Once again, thank you for taking the time to spend this hour with me explaining to you about what I believe to be one of the greatest new breakthrough inventions in the last several years. I've been very pleased to have this and add this to my armamentarium to help patients live better with less pain and get back to and enjoy their lives so much more. So thank you for taking this time.
All right. Thank you, everyone. That concludes the program for this evening. Hope you have a great night, and please reach out to Dr. Galland and the OrthoNC team to learn more and schedule an appointment.